thousands are raving about our best-selling 100-patient scenario book, and so we started creating the expansion books to go along with it, including the cardiac arrest scenarios, we have the airway scenarios, pediatric scenarios, and the MCI scenarios. And you can get this entire bundle at the link in our bio. This is MasterMedics. MasterMedics is an online learning tool made specifically for EMT and paramedic students. We've had 10,000 students come through us to transfer this textbook knowledge into their minds. And it works because it's fun, it's visual, and it's engaging. And if you want to try it out for yourself, you can start a 3-day free trial right now at the link below. Is going to affect your patients and how you need to treat them differently than basically any other type of shock because of some very unique pathophysiology that's going on. So pretty interesting case that we're going to be covering today. So hopefully you guys are excited. Before we get started, I'm going to let everyone kind of get in here and see what we're doing here. So if you need to go grab a water or something like that, go ahead and do that. We're not going to get started for another minute or so. And in that minute, I'd love to know where you all are watching from. Where in the world are you watching from? We'll do a little roll call here while we're kind of waiting for everyone to pop in. So go ahead, put that in the comments. Where are you all from right now? Where are you guys watching from? Florida? Where else you all from? Cape Breton Island, Oman, where else? Liverpool, UK, awesome. Michigan. Oh, fantastic, Jay. Looking forward to it. Hopefully you can learn a little bit more. Jamaica, Costa Rica, Toronto, British Columbia, India, Singapore, Columbus, Ohio. Nice. This is fantastic. Cornwall, UK, North Central Idaho. Fantastic. Well, it's great to see you all. And hopefully you guys are all excited. Sofia, Bulgaria. I've actually been to Sofia, Bulgaria. Been to Serbia. Texas, Alberta, my stomping grounds. Saudi Arabia. Haven't made that part of the world yet. Tennessee, Florida, Nottingham. Haven't been to Nottingham either. Southwest Arizona, nice. Pakistan, Nigeria, Australia, awesome. Well, it's great to see everyone. Today we're going to go ahead and start talking about neurogenic shocks. I think neurogenic shock is a pretty interesting topic, something that we don't see every day, but it's certainly something that you need to understand if you want to be able to treat them in a way that's going to be effective, because there are some weird things going on with these particular patients. And so let's get right into it and treating this neurogenic shock patient. Okay, so for those of you maybe coming on for the first time here and watching our live, my name is Geoff. I'm the owner and lead educator with MasterMedics. MasterMedics does a lot of things, but really what we do is we revolve ourselves around the education of paramedics and EMTs all over the world. We have thousands and thousands of members that come to our classes, come to and use our premium services in order to help them through school, help them with continuing education in a more exciting way. We even do conferences that are happening in Canada as well. We partnered Flightbridge Ed for those. And we have publications as well. We have books. And so whatever way that you learn paramedicine, we have provided that to you. And so if you're interested in checking those things out, becoming a member is probably the best first step. Checking it out for free, see if you like it, and if it's for you, you can stay as long as you like, and you get access to a lot of the publications, you get access to the information of the conferences and everything like that. So that's probably your first step to check out. We would love to have you there and work with you. So let's take a look at this case. So we have a male patient that was at the end of a trailhead following a call from a bystander. So they witnessed this male cyclist tumble down a steep hill and collide with a tree at high speed. Upon arrival, you find a 32-year-old male patient lying supine at the base of the hill. He's alert but visibly anxious and in distress. His helmet is intact but shows evidence of significant impact. The patient states he cannot feel or move his legs. He denies head injury symptoms such as loss of consciousness or blurred vision, but reports severe pain in his neck and upper back. With that, I also want to wish all of our US folks a happy Thanksgiving weekend as well. Forgot about that because Canada, yeah, we had it last month. So anyways, okay, so this is your patient. You find them, sorry, not supine, but you're going to find them prone in this position here. Can't move their arms, can't move their legs, and you find a significant compression to the cervical spine. So that's essentially what you find with this particular patient. They are conscious and talking to you. You set them on the vital signs, and this is what you see. So based on your presentation that you have with your patient and based on these vital signs, what are some things that really are concerning to you? What do you see here that's concerning? Heart rate and BP. Bradycardia, blood pressure, heart rate, and ETCO2. ETCO2 is okay. Blood pressure, heart rate, ETCO2, pressure, cardiac pressure, yeah, all of it, yeah, fair. Blood pressure, blood. Yeah, so there's the biggest kind of factor that you have here is going to be this guy right here. This is an end result is what I would call that. That's an end result of the pathophysiology of what's happening. This is what this patient is suffering, is they are in a decompensated or a non-compensated state of shock, which is unfortunately causing significant hypoperfusion, which is another fancy word for shock. And so what's interesting about this patient is not only do they have low blood pressure, but they have an unusually low heart rate. Okay, they have an unusually low heart rate, which is pretty weird for a patient that's in shock, right? And so that's something that we should take note of for sure, that they're in a pretty significant bradycardia despite having a low blood pressure. So why is that? Well, there's a misconnect or a break in communication between the brain itself and compensating factors. And so you have your ability to send signals through the spinal cord itself. And so if you have an injury or a significant injury to the vertebrae of, say, T6 and above, in this particular case, it's actually in the cervical spine that we have the injury, then we can't send signals through the spinal cord and through these peripheral nerves to the heart and to the vessels. And what ultimately is going to happen is that the vagus nerve itself, which is part of the parasympathetic nervous system, not the sympathetic nervous system, the parasympathetic nervous system is going to be unaffected in these cases. It's really only the sympathetic nervous system that ultimately is going to be really altered in these particular cases, because the sympathetic nervous system requires stimulation and signal, where the parasympathetic nervous system requires dormitory status is essentially the kind of the thing. And so when we can't send active signals to the heart or to the vessels, then they can't be stimulated to increase the heart rate or increase contractility, or in the vessel's case, they can't be squeezed. That's what's happening here, is that we can't send those sympathetic signals to compensate for what's occurring here. So that's essentially what your issue is that it's twofold. Is that one, you have a sensory issue at the vessels, where these vessels are no longer constricting. They think that we need to just relax, okay? Because without the sympathetic nervous system, that's their normal state, is that they just relax when they have an overabundance of parasympathetic tone. And so they relax and blood starts to pool in the venous side of the system. And when that occurs, we have a decrease in cardiac output because we have a decrease in blood returning back to the heart because it's just sitting in the venous side. And so that's where this blood pressure problem comes into play. Now, in someone that has a normal, vertebrae and uninterrupted signals, then signals from the medulla would be sent to the heart rate, to the heart itself, to say, hey, I need you to pump faster, I need you to squeeze harder, and I need those vessels to squeeze and clamp down. Okay, but because we can't send those signals, those things don't occur. And this is kind of the formula to in where blood pressure comes to be and where shock is all the issue. Is that, remember that we have a blood pressure problem right now, and the main culprit of that blood pressure problem is actually systemic vascular resistance. That's a fancy word of saying how much pressure is against the vessel walls of any individual vessel. That's what systemic vascular resistance is. How much pressure is in the pipes pushing against the edge of the pipes or the side of the pipes. That's what the vascular resistance is. And in a neurogenic shock, when we have no sympathetic tone, those vessels will loosen, they will expand or dilate. And when they do, this pressure against the walls reduces, okay? Because the bigger the tube, okay, you didn't increase volume or anything like that. So the bigger the tube with the same amount of volume, we have less resistance. And when we have less resistance, ultimately, that means we have less pressure. Okay, so that's your pathophysiology. That's your problem. Now, when this occurs, like we said, that means that usually our heart rate would increase, our stroke volume would increase, and then in a sympathetic tone situation where we're compensating for something, the sympathetic vascular resistance would increase because we would try and clamp down those vessels, but we can't do those things. And so neurogenic shock isn't just a shock in itself or a unique type of shock. It's what we would consider a non-compensated, non-compensated shock, because we're unable to compensate for the problems that are occurring. And this is unique to this neurogenic shock, because all other shocks ultimately would have a compensation to try and maintain things to compensate for the hypoperfusion that's occurring. But because of the issue or the problem that we have with the spinal cord, that compensation doesn't occur. Okay, so now that we know a little bit about the pathophysiology and the problem that we have, how do we start to solve it or help this patient? Well, we have really two main things that we can do to help this. Remember, our problem is the vessels, right? So our problem being the vessels, what we want to do is that we want to target those vessels to try and improve their tone, improve the systemic vascular resistance. And so in doing that, we need to do one of two things. We either need to fill those those vessels with more fluid to improve the systemic vascular resistance, okay, or we need to clamp those vessels down. So in your particular case, from an EMS standpoint, you have an opportunity to possibly give fluids, okay, or you could start using a bag of norepinephrine and start doing a drip, or norepinephrine as well. Because you remember, the whole purpose is to try and clamp down those vessels. And if we can clamp down those vessels, then we should start to see a restoration of blood pressure. So with these particular patients, the first thing is probably starting with a little bit of fluids. If they are unresponsive to the fluid, which they often are, because our problem isn't a fluid problem, our problem is vessel dilation and the subsequent pooling of blood in the venous side. Adding fluid might help some of your vascular tone and might help some of your cardiac output, but often it's not going to be a huge response, and often transient, meaning that you might see a bump in blood pressure for a few minutes, and then eventually that blood pressure will subside as this fluid pools in that venous side. And so this might be a temporary solution if you have a 5-minute drive to the hospital. But if you're in a rural setting and you have a 35, 40, 50-minute drive to the hospital, putting so much fluid in them isn't really going to be the solution. The solution is going to be a vasopressor like epinephrine. Now, the reason I believe that epinephrine is the primary choice, not saying that norepinephrine can't do what you want, but epinephrine is also going to introduce the neurotransmitter epinephrine into the body, and we know that epinephrine has a significant impact on not only the alpha side and squeezing vessels, but also the beta 1 side, which is the heart rate and contractility side. So we're going to get the heart, the compensation factors that we're missing out of this patient, and we're going to get the vessel squeeze out of your epinephrine. Whereas for norepinephrine, you're going to get the squeeze, but you're not really going to get the beta 1 or the heart effects that you would like. And so epinephrine kind of overall makes more sense because it's the primary sympathetic mechanism or sympathetic neurotransmitter that's going to allow for solving a lot of our problems. And so these two in combination are probably your best bet, whereas using epinephrine aggressively is probably a smart choice in this particular patient. So any questions with this particular patient? Go ahead, put it in the comments. I'm going to go back and see. Congratulations, you passed registry. That's fantastic. I'm just going so parasympathetic is the body's default regardless of nervous system status. Yeah, because the vagus nerve, basically where the parasympathetic nervous system and the sympathetic nervous system, they're always kind of in combat with each other depending on the situation. So if I was standing here and all of a sudden a dog comes running through and I don't know this dog, he starts barking at me, my sympathetic tone is going to recognize I'm in danger and start to overcome my parasympathetic tone. Okay, that's kind of how that works, by pumping me full of epinephrine and norepinephrine and dopamine and serotonin in order to make decisions faster, in order to increase my heart rate, and so on and so forth. When my body is no longer in danger, then my parasympathetic tone is going to take over by introducing more acetylcholine. And so they're always in combat with each other depending on your state. When you but acetylcholine is a very abundant neurotransmitter, which is primary on the parasympathetic nervous side. And so when you take away the sympathetic nervous side in a spinal shock, then your parasympathetic tone starts to overcome because there's just an abundance of acetylcholine compared to norepinephrine in regular state. And so that's why you see that parasympathetic overtake in these situations, because there's just an abundance of the acetylcholine that allows for that to occur because there's no pushback from the sympathetic side. High heart rate, but low blood pressure. No, low heart rate. Low heart rate and low blood pressure. Takes some time. I know EMR to PCP is a big jump, but it takes time. Keep learning your physiology. It will help a lot. What if the patient with an autonomic sympathetic response with a high but has low blood pressure? Well, it wouldn't really matter because in this particular state, you would still want to treat that hypotension. And so, yeah, if even if they did have a high heart rate, then you still need to treat that blood pressure. And so that would be in a case that maybe norepinephrine might be a better choice because then you're not going to play into that. If I'm correct that the solution is going to give us 15 micrograms per cc and the dosage is 10 per minute, how would you apply that? In this particular case, I would probably be starting at 5 micrograms per minute and working my way up from there. A lot of the time, it doesn't take much to really stimulate that vessel squeeze, but I'm probably working at 5 and working my way up from there. And if I needed to, I can turn it down. Nice thing about epinephrine is it has a pretty short half-life. And so if you do overshoot a little bit, it won't take long for that medication to kind of dissipate. What about push dose epi? With push dose epis, push dose epi is fine if that's what you have. Just know that you're going to be redosing it on a pretty regular basis. I would suggest somewhere in the range of 10 micrograms for your push dose, and then rechecking blood pressures literally like every 3 to 5 minutes to see if you need to redose, which you likely will in that range of 3 to 5 minutes. 10 micrograms will burn off quick. So I would highly suggest checking the blood pressure on a pretty regular basis. But yeah, push doses are fine if that's what you have. You need to recert in March. Well, we are CAPC accredited. So if you want to recert with us, you certainly can. Would Ringer's lactate be a better option? In this particular situation, there's not a huge difference between normal saline and Ringers in this particular situation. I'm a bigger fan of Ringers as opposed to normal saline. But in this particular situation, the differences between them from a physiological standpoint aren't massive. I would just say that you want to limit the fluids as much as you can and only trying to maintain a blood pressure of a systolic of 90. And then once you get that, then you want to dial down your fluids, regardless if it's the normal saline or if it's Ringers. So you'll just use a pump? Yeah, typically I would use a pump in these particular cases. This patient needs or requires a consistent dose of epinephrine. So a pump is going to give you the most consistent. ADHD approved? Well, similar to you. I got a little bit of ADD myself. Should we focus more on MAP instead of systolic? Yeah, I mean, in a grand scheme of things, the question is, should we be focusing on MAP as opposed to systolic blood pressure? I'm always been a fan of mean arterial pressures because it's your constant flow of blood pressure. That's really what mean arterial pressure is, right? And so I've always been a proponent of focusing on a mean arterial pressure as opposed to a systolic pressure. Because if you think about it, systolic pressure is your peak pressure that only happens. That's the flow of blood that you have for a third of the time. The other 2/3 of the time is your diastolic pressure or low flow. And so your mean actually is telling you a better picture of how much flow you're getting at a constant. And if you're keeping that above 65, then you have a pretty good indicator that you are getting a constant flow of perfusion to cells. If you're below 65 of mean arterial pressure, then you're not. Having a systolic of 90 is a fine benchmark for most things. But if you really want to be specific and understand more about kind of how your patients are going to physically work and so on and so forth, a mean arterial pressure is a better benchmark of how your patient is doing at a regular basis, not just how they're doing 1/3 of the time with their blood pressure. Let's see. I don't know if I see any more questions. Maybe I hit them all. This is good. Would you open up a drip or keep a TKO? I'm fine with the drip. And then, like I said, once I get this patient to a sustainable blood pressure, then I'm going to shut that drip down to a TKO. You don't need to be giving fluids to this patient. Fluids, are, like I said, are kind of a transient thing for these patients until you actually fix the problem, which is your vascular resistance or your vascular dilation. That's the issue. So think of this patient in kind of like a distributive type of shock. Essentially, is that they have really wide vessels that's causing a distribution of fluids. If you can clamp down those vessels, you're going to solve a lot more of your problems. Whereas if you introduce an abundance of fluid, you're not going to solve your problems nearly as well. So yes, fluids can be a benefit in these patients, but if you want to target the problem, your problem is vessel constriction. Just want to make sure there's no more questions before I sign off here. I think we're good, hey? What about mannitol in the place of fluids? I don't think there's a whole lot of precedent there. The idea with mannitol, and I know where you're kind of like mannitol being an osmotic diuretic. The idea with mannitol is that you're going to pull fluid that has now left the vessels into the vessels themselves. And that can give you an increase in fluid. It's very similar to 3% saline. A colloid solution or a hypertonic fluid has been tested for this particular thing as opposed to using isotonic fluids because it promotes fluid to move from these extracellular areas that are not in the vessels and promote fluid to move into the vessels. That's what 3% saline and mannitol will do. The problem with that is that not only does it pull fluid from these extracellular areas into the vascular space, is that as soon as you introduce them, the kidneys will start to attempt to flush out excess fluid and excess electrolytes. And so you're only getting a transient bonus for a short period of time in these particular cases because not only do they have this mechanism pulling fluid into the vascular space, they're ultimately going to remove all that fluid through the kidneys. And so, again, you only get a transient bonus out of that. I get everyone? No problem. All right. Well, I'll leave you with that. Thanks again for joining me. Again, if you benefited from the way that I teach, we would love to have you as a Master Medics member. You can check us out on our social media pages. And if you are interested in seeing us live, we are doing a live show or a live conference next September in Calgary, Alberta. We would love to see you there. Details are inside the links in our bio. Becoming a member is usually the first step for everyone to kind of learn a little bit more about us. We would love to have you there. You can join for free and just check out to see if it's something that you'd really enjoy. And we would love to have you there. So thanks again for joining me today. I'll leave you with that, and we'll see you next time. Bye for now.